Welcome back to the deep dive. We are cutting through the noise and taking a massive shortcut to becoming truly well-informed. Our mission today is a comprehensive deep dive into the cellular architecture of the body's transport system, the cardiovascular system.
That's right.
We're drawing all of our insights from a detailed chapter in a major histology textbook, translating all that complex structural information into functional, memorable knowledge for you.
And we really are going from the macro to the micro. I mean, we're not just naming parts, we're detailing the relationship between structure and function.
Okay, so from the heart's pumping action right down to a single cell.
Exactly, down to a single endothelial cell. And understanding how these specialized tissues and even the proteins they secrete govern blood flow, pressure, and, the body's entire critical transport logistics.
So let's start at the top. When we say cardiovascular system, what are we really talking about?
We're talking about the network responsible for moving blood and lymph. And with them, everything vital. Cells, nutrients, hormones, waste products, immune components, all of it throughout the entire body.
And it all relies on three main components.
Three core components. You have the heart, which is the muscular high-pressure pump.
Right.
Then you have the blood vessels, arteries, capillaries, veins. That's the fixed route for all the circulation. And finally, the lymphatic vessels, which act as this essential, super efficient drainage and auxiliary system.
The pressure dynamics are just fascinating. The heart pushes blood into the arteries under incredible pressure.
Immense pressure. But that pressure is almost entirely gone by the time the blood makes its way back.
So the return trip is a low-pressure environment.
Completely. The venous side relies on external help to get the blood back to the heart.
And that help comes from two main factors.
Primarily two things, yes. First, the negative pressure you create in your chest, your thoracic cavity when you breathe in. It literally pulls blood toward the heart.
And the second?
The constant compression from your skeletal muscles. Every time you move, your muscles are squeezing the veins, pushing that low-pressure blood along.
And the whole point of this huge pressure gradient is to get to the exchange zone.
The exchange zone. That's the blood capillaries, the narrowest vessels in the body. This is where the real work happens.
This is where plasma, carrying oxygen and all the metabolites, actually passes through the capillary wall into the tissues.
Right. And in return, the capillaries pick up carbon dioxide and metabolic waste from those same tissues.
It's interesting how the fluid balance works here. Most of the fluid that leaves the vessel gets recaptured almost immediately on the venous side of the capillary bed, but not all of it.
Not all of it, no. That's a key point. We figure about 10% of that fluid that seeps out into the tissue, along with any proteins that leaked out with it, actually enters the lymphatic capillaries.
And that fluid is now called lymph.
It's officially lymph. And the lymphatic system's entire job is to collect it and make sure it eventually gets returned to the bloodstream. This is critical for maintaining your body's overall fluid balance.
Where does that return happen?
It happens where the major lymph ducts drain back into the blood, specifically right around the junction of the internal jugular and subclavian veins.
We should also pause here and talk about the cellular traffic.
Yeah.
Because while capillaries are the site for nutrient exchange, they aren't the main exit for immune cells.
No, they're not. White blood cells, especially when there's an inflammatory response, they primarily leave the bloodstream at the postcapillary venules.
Which are a bit larger.
A bit larger and structurally different, yeah. And that exit process, that emigration, it requires this whole coordinated action where the endothelial cells have to express specific adhesion molecules to literally guide those immune cells out of circulation and into the tissue that needs them.
This brings us to what's called the microcirculatory unit. It's not just a random jumble of vessels, is it?
Not at all. It's a functional team. It's the functional regulatory unit of your entire circulation.
So what defines it?
It's defined by three parts: the arterioles, the capillary network they feed into, and the postcapillary venules where the blood collects before heading back to the heart.
And of those three, which one is really in charge?
The arterioles. They are the key operational managers. Their smooth muscle walls contract and relax, and they act as the primary flow regulators. They decide exactly how much blood gets into that delicate capillary network at any given moment.
Okay, so zooming out even further, we've got the two big loops of the body, the pulmonary and the systemic circuits.
Right. The pulmonary circulation is the short, low-pressure loop. It takes deoxygenated blood from the right side of the heart, sends it to the lungs for a gas exchange.
To pick up oxygen.
Exactly. And then it brings that newly oxygenated blood back to the left atrium. That's it.
And the systemic circuit.
That's the high-pressure long-haul loop. It takes that fresh, oxygenated blood from the left side of the heart, and drives it out to supply every other tissue in your body. Then it returns the deoxygenated blood back to the right atrium to start all over again.
And if you just look at the heart itself, the anatomy tells this whole story.
Oh, absolutely. If you could hold a human heart, the difference in muscle is striking. The atria are really thin-walled. They only have to pump blood down into the ventricles right next door.
But the ventricles are a different story.
They're a completely different story.
Yeah.
The left ventricle has to be dramatically thicker and more muscular than the right. Why? Because it's driving that entire high-pressure systemic circulation against massive resistance, while the right ventricle only has to push blood through the short, low-resistance pulmonary circuit in the lungs.
We should probably also mention the exceptions to these simple pathways, the portal systems.
Right. A portal system is like a circulatory detour. Instead of the usual artery to capillary to vein route, you have a vein or an arteriole sitting between two separate capillary networks.
And there are a couple of really well-known examples.
The two big ones are the hepatic portal system, which connects the capillaries in your gut to the capillaries in your liver, and the hypothalamic hypophyseal portal system, which is absolutely crucial for endocrine regulation in the brain.
All right, let's move our deep dive into the pump itself, the heart. It's positioned obliquely in the middle mediastinum, and it's encased in this tough protective sheath, the fibrous pericardium.
And we need to detail the architecture of the wall moving from the outside in.
Okay, so 3 layers.
3 continuous layers. The outermost layer is the epicardium. Histologically, it's a single layer of flattened mesothelial cells on top of some connective tissue and fat. It's also the visceral layer of the serous pericardium.
And that fatty tissue isn't just for cushioning, is it?
No, not at all. It holds critical cargo. All the major coronary vessels, the arteries and veins, and the nerves that regulate heart function are all housed within the connective tissue and adipose tissue of the epicardium.
Then that layer folds back on itself.
It reflects or folds back at the base of the great vessels, and that forms the parietal layer of the serous pericardium. And this creates the pericardial cavity.
Which is really just a potential space.
A potential space, yes. It usually just contains a tiny bit of lubricating serous fluid.
But because that pericardium is so tough and fibrous, this cavity can become a serious problem if fluid builds up too quickly.
That is a huge vulnerability, and it's called cardiac tamponade. This isn't just a little fluid accumulation, it's a true medical emergency.
A race against time.
Absolutely. If blood from a trauma or some other effusion fills that tiny space fast, the rigid fibrous pericardium doesn't let the heart expand, so the external pressure literally crushes the heart chambers, and they can't fill properly.
And it doesn't take much fluid to be fatal.
Not if it's acute. Even 100 milliliters can be enough. The immediate treatment is pericardiocentesis, where you go in with a needle and drain that fluid to relieve the pressure.
Okay, so moving inward from the epicardium, we hit the massive middle layer.
The myocardium, the muscle powerhouse. It's entirely composed of cardiac muscle cells.
And this is where we see that thickness difference again.
Right. The atrial myocardium is a very thin, low-pressure job. The ventricular myocardium, especially on the left side, is substantially thicker. It's the histological adaptation needed to generate the immense pressure for systemic circulation.
And finally, the innermost layer, the endocardium.
The endocardium lines all the internal surfaces. It starts with a simple squamous endothelium, then some subendothelial connective tissue. Beneath that, there's a middle layer with some smooth muscle cells, and then the deepest layer,
The subendocardial layer.
the subendocardial layer. And this one is crucial because it merges with the connective tissue of the myocardium, and critically, it's where you find the heart's electrical conducting system.
We'll get to the electrical system in a moment, but first, let's talk about the mechanical support, the fibrous skeleton. It sounds abstract, but it's this incredibly important piece of dense connective tissue.
It really is the scaffolding of the heart. A complex network of dense, irregular connective tissue that forms 4 fibrous rings right around the openings of the heart valves.
And these rings are attachment points.
Indispensable attachment points for the leaflets of all 4 valves. They also serve as the anchor for the atrial and ventricular muscle masses.
But it has a secondary function that's just as important, right?
Its function as an electrical insulator is absolutely vital. The fibrous skeleton is the only thing that stops electrical impulses from spreading chaotically between the atria and the ventricles. It forces the impulse to funnel through one specific path, the AV bundle, which guarantees a coordinated contraction.
And all this hard-working muscle needs its own dedicated plumbing.
That would be the coronary vasculature. The right and left coronary arteries branch right off the base of the aorta to supply the heart muscle. After that, the venous blood drains primarily into the coronary sinus, which is a large vessel that empties directly back into the right atrium.
Okay, with that framework set, let's look closer at the heart valves. They attach to those fibrous rings, and they are these complex layered structures.
Bizarre. We can identify three distinct connective tissue layers in each valve cusp, and they're all covered by the endocardium. The layer that provides the core strength is the fibrosa.
And its location depends on the valve.
It's always on the high pressure side. So the ventricular side of the AV valves or the arterial side of the aortic and pulmonary valves, it's packed with type I and type 3 collagen, giving it that stiffness.
And in the AV valves, this strong layer extends right down into the chordae tendineae.
Yes, those rope-like cords. The fibrosa layer is what gives them their incredible tensile strength.
Okay, moving inward, the next layer is the spongiosa.
The spongiosa. And the name tells you a lot.
It sounds soft.
It is. It functions like a gel suspension, a cushion. It's made of loose collagen and elastic fibers in this matrix that's rich in proteoglycans, so it holds a lot of water.
So it's the shock absorber.
It's the shock absorber. The fibrosa provides the strength, but the spongiosa absorbs the shock and gives the valve the flexibility it needs for the leaflets to meet perfectly when they close, which prevents any backflow.
And the third layer.
That's the ventricularis, or atrioles, depending on which chamber surface it faces. It's dense connective tissue, rich in elastic fibers. Its job is dynamic. It allows for the rapid extension and recoil of the valve leaflet during each heartbeat.
A really important point here is that the valve cusps themselves are normally avascular. They have no blood supply.
Right, they rely on diffusion, but they still need to be maintained. And that job falls to the valvular interstitial cells, or VICs.
And what do?
Normally, they're quiet, sort of like fibroblasts, just maintaining the matrix, but they are highly reactive. During disease, they can transform into these activated myofibroblast-like cells.
And then they start remodeling things.
They start remodeling, synthesizing new matrix components and enzymes, and often they contribute directly to the pathology.
Which leads us straight into the clinical side of things. Heart valve diseases.
The damage falls into three distinct histological categories.
The first one is degeneration of the extracellular matrix. The classic example here is myxomatous mitral valve disease.
So the matrix breaks down?
The collagen and elastic fibers break down. The valve tissue loses its integrity. It gets weak, floppy. Functionally, this leads to a valve that prolapses, it bows backward, and causes significant leakage or regurgitation.
The second category is fibrosis. Scarring.
This is what you see in rheumatic heart disease, often a delayed result of rheumatic fever. The inflammation, or valvulitis, triggers massive collagen buildup, and you lose the functional elastic tissue. The valve becomes thick, rigid, inflexible.
And that leads to stenosis.
Right, a pathological narrowing of the valve opening. And what's really striking histologically is that this inflammation can actually trigger angiogenesis, new blood vessel growth in these normally avascular valve cusps.
And the final category is often related to aging. That is nodular calcification, or degenerative calcific aortic valve stenosis. It's very common in older patients, or those with chronic kidney disease. Calcium deposits build up in the leaflets, they harden, become inflexible, and you get aortic stenosis, which obstructs blood flow out of the left ventricle.
All right, let's switch from the mechanical to the electrical. The heart's intrinsic rhythm can beat on its own, completely independent of any nerves.
And that's because of the specialized cardiac conducting cells. The impulse begins in the sinoatrial node, the SA node, high up in the right atrial wall.
And that's the primary pacemaker.
It's the dominant pacemaker because it spontaneously depolarizes at the fastest rate, about 60 to 100 times a minute.
The impulse then spreads across the atria and gets collected at the next node.
The atrioventricular node, or AV node, it's the secondary pacemaker, a bit slower, around 50 beats per minute. But crucially, the AV node introduces a slight delay.
Why is that delay so important?
It allows the atria to finish contracting and completely empty their blood into the ventricles before the ventricles start to contract. It's all about timing.
From the AV node, the signal has only one way to go, past that insulating fibrous skeleton.
Right, through the AV bundle, or the bundle of his. This then branches into the final delivery system running through the ventricle walls.
The Purkinje fiber.
The Purkinje fibers. And these are modified cardiac cells that are built for speed. They conduct the impulse about 4 times faster than regular heart muscle, which ensures the massive ventricular muscle contracts in near-perfect sync.
And they look different under a microscope, don't they?
Oh, very different. They're much larger than regular ventricular muscle cells, and they look pale, almost empty.
Why is that?
That paleness is from their huge glycogen content. It's their dedicated internal fuel tank, and it makes them much more resistant to hypoxia low oxygen than the surrounding muscle. It's a key survival feature.
And this whole system has a clear hierarchy of control.
It does. If the SA node fails, the AV node takes over at 50 BPM. But if you have complete heart block, a total electrical break, the ventricles have to rely on the Purkinje fiber's own rhythm,
Which is very slow.
dangerously slow, only 30 to 40 beats per minute, often not enough to sustain consciousness.
And there's a specific clinical condition tied to this.
Sixth sinus syndrome, or SSS. It's often due to age-related degeneration of the SA node cells. The pacemaker becomes unreliable, and you get these irregular rhythms, sometimes too slow, bradyarrhythmia, sometimes too fast, tachyarrhythmia. This is a very common reason for implanting an electronic pacemaker.
And we monitor all this with an ECG.
Right. The electrocardiogram just records that coordinated spread of electrical activity. Those waveforms, the P, QRS, and T waves, give us critical diagnostic information about rate, rhythm, and conduction.
So while the heart has its own beat, the nervous system acts as a fine-tuner. Systemic regulation.
It regulates the rate but doesn't initiate the beat. The parasympathetic system, mainly via the vagus nerve releasing acetylcholine, is the brake. It slows the heart rate, reduces contraction force, and constricts the coronary arteries.
And the sympathetic system is the gas pedal.
Exactly. Using norepinephrine, it increases the rate tachycardia and increases the force of contraction. And opposite to the parasympathetic action, it actually dilates the coronary arteries to get more blood to the hard-working muscle.
Hormones and other chemicals also play a big role.
Absolutely. Hormones like epinephrine, things like caffeine, are positive agents. They increase rate and force. Then you have drugs like propranolol or calcium channel blockers that act as negative agents, slowing things down.
And finally, the central nervous system needs to know what's happening out in the periphery.
It gets that feedback from specialized sensory receptors. You have baroreceptors in the carotid sinus and aortic arch that monitor high arterial blood pressure.
Okay.
Then you have volume receptors in the atrial and ventricular walls that sense low pressure and how much the heart is stretched. And finally, chemoreceptors in the carotid and aortic bodies are constantly tasting the blood for changes in oxygen, CO2, and pH.
All right, let's move from the pump to the plumbing. The structure of the blood vessels. Whether it's a huge artery or a tiny venule, they all share this universal three-layer architecture. The tunics.
3 concentric layers from the inside out. The innermost layer, right next to the blood, is the tunica intima. It's always lined by that simple squamous endothelium sitting on a basal lamina with a thin subendothelial layer underneath.
But in arteries, the intima has a very clear border.
It does. The internal elastic membrane, or IEM, it's a sheet of elastic material that's fenestrated, meaning it has little window-like openings in it.
Why the openings?
They're critical for diffusion. They allow nutrients from the blood to get through to the deeper cells in the vessel wall that don't have their own blood supply.
Okay, next up is the thick middle layer, the tunica media.
This is the powerhouse layer, mainly defined by its circumferentially arranged smooth muscle cells. In arteries, it's usually the thickest layer, sitting between the IEM and the external elastic membrane, or EEM. It also has varying amounts of elastic tissue, which the smooth muscle cells make themselves.
And the final, outermost coat.
The tunica adventitia. It's mostly longitudinally arranged collagen and some elastic fibers. Its thickness varies a lot between vessel types. It's pretty thin in most arteries, but it's the thickest major structural layer in veins and venules.
And within the adventitia of bigger vessels, we find their own personal supply system.
We do. We call them the vasa vasorum. Literally, the vessels of the vessel. Little arteries and veins that supply the outer parts of the vessel wall. We also find the nervi vasorum here, the autonomic nerves that control the smooth muscle in the media.
Now, for a long time, the endothelium was just seen as a passive lining. But we now know it's a massive, highly active organ.
Oh, it's incredibly active. A continuous sheet of cells acting as this dynamic interface between the blood and the tissue. And its functional properties can change rapidly in response to its environment. We call that endothelial activation.
And that activation is the starting point for disease.
It's the foundational starting point for basically every major vascular disease, especially atherosclerosis. Triggers like high LDL, hypoxia, or infection kick it off.
Let's break down the 5 major functions of the endothelium. Function number 1.
Maintenance of a selective permeability barrier. It regulates what gets through. Small molecules like oxygen diffuse easily. Bigger stuff like cholesterol needs active transport, like transcytosis.
Function 2 is about preventing clots.
The non-thrombogenic barrier. This is critical. Healthy endothelium actively prevents clotting by secreting anticoagulants like thrombomodulin and antithrombogenics like PGI2. But the second it's damaged,
It flips a switch.
instantly, it starts releasing prothrombogenic factors like von Willebrand factor, which kicks off the whole clotting cascade.
Function 3 is modulating blood flow.
Modulating blood flow and vascular resistance. It does this through a beautiful balancing act between vasodilation and vasoconstriction.
Okay, function 4.
Regulation of cell growth and immune responses. It secretes growth factors that control smooth muscle proliferation, and it orchestrates inflammation by expressing adhesion molecules that tell immune cells where to get off.
And finally, function 5, lipoprotein metabolism.
Right. Endothelial cells generate free radicals that oxidize lipoproteins, especially LDL. This oxidized LDL is highly pathogenic. Macrophages in the vessel wall then gobble it up, turning into fat-laden foam cells, which is the very first sign of plaque.
Let's zero in on that flow modulation, starting with vasodilation. The big player here is nitric oxide, NO. What's the trigger?
The main trigger is shear stress, the frictional force of blood dragging against the endothelial surface. This mechanical signal activates an enzyme, ENO.
And ENOs makes the NO.
It makes NO, which is a gas. It diffuses out of the endothelial cell and into the smooth muscle cell underneath. There, it activates another enzyme, guanylate cyclase.
Which produces the signal for relaxation.
Exactly. It generates CGMP, which activates protein kinase G, or PKG, and PKG's job is to lower the concentration of calcium ions inside that muscle cell. Less calcium means relaxation, which means vasodilation.
The opposite of that is vasoconstriction, and this is driven by endothelins.
Endothelins are peptides. And endothelin 1 is the most potent vasoconstrictor known to man. They're made by the endothelial cells and act locally.
How they work.
ET1 binds to ETA receptors on the smooth muscle cells, and this starts a cascade that increases calcium release inside the cell. More calcium means strong, sustained contraction and a big increase in vascular resistance.
That's a delicate balance.
A very delicate balance. Dysfunction happens when the scale tips. For instance, if you have less NO production, that contributes directly to vasoconstriction and hypertension.
Let's move to the major clinical insights, starting with atherosclerosis. This is a sequential process.
It is. It starts with endothelial dysfunction, often from things like smoking or high blood pressure. The endothelium gets leaky, and LDL slips into the intima and gets oxidized.
And that triggers an immune response.
Right. Monocytes are attracted, they migrate into the intima, and they differentiate into macrophages.
And these macrophages become the telltale sign of early damage.
They do. They start frantically engulfing all that oxidized LDL. They get so full of fat that they swell up and become what we call foam cells. A collection of these foam cells is the earliest lesion, the fatty streak.
What's the next step?
Smooth muscle cells from the tunica media migrate into the intima. They're triggered by growth factors, and they start laying down a tough fibrous matrix, mostly collagen. This forms a fibrous cap over the growing core of lipids and necrotic junk, and that's your full-blown atheromatous plaque.
And as it grows, the signs get more obvious.
You see necrosis, calcification, and cholesterol crystals. Because the crystals dissolve during sample prep, they leave behind these visible needle-like spaces called cholesterol clefts, a dead giveaway of an advanced lesion.
And the real danger is rupture.
Instability, yeah. If that fibrous cap ruptures, the contents are exposed to the blood, and that instantly triggers a thrombus, a clot, which can block the whole vessel and cause a heart attack or stroke.
The second major clinical issue is hypertension. How does chronic high blood pressure remodel the vessel wall?
It puts enormous stress on the small arteries and arterioles, and they remodel in response. We see two main histological changes. First, chronic contraction of the smooth muscle cells, and second, an actual increase, a proliferation of the amount of smooth muscle tissue in the tunica media.
So high blood pressure leads to a thicker media, which creates more resistance, which feeds the cycle.
Precisely. That's the histological signature. A narrower lumen with a thicker tunica media. And this chronic pressure overload has a direct impact on the heart itself, leading to compensatory left ventricular hypertrophy.
The heart muscle gets bigger to cope with the workload.
The muscle cells increase in diameter, the wall gets thicker, but it also becomes less elastic. And if it's left untreated, that compensatory thickening eventually fails, leading to cardiac failure.
All right, now let's get into the different types of arteries. They're classified into 3 types based on what's in their tunica media, starting with the biggest, large or elastic arteries, like the aorta.
Functionally, they're more than just pipes. They're pressure reservoirs. During systole, they stretch to absorb the surge of blood. Then, during diastole, that elastic recoil keeps the pressure up and ensures blood flow is continuous, not just pulsing.
And their histology has to support that.
It does. The tunica media is the dominant layer, and it's defined by an incredible amount of elastin. We're talking dozens of concentric, fenestrated elastic sheets, up to 70 layers stacked like rubber bands.
And the endothelial cells in these arteries have specialized cargo.
They do. Weibel Palade bodies. These rod-like inclusions contain two key molecules, von Willebrand factor for initiating clotting, and P-selectin, an adhesion molecule for guiding neutrophils during inflammation.
Okay, next are the medium or muscular arteries.
This is most of the named arteries in your body, and their structure shifts dramatically to reflect their function, which is distributing and regulating local flow.
So more muscle.
Predominantly smooth muscle in the tunica media, with much less elastin. And the key distinguishing feature is in the tunica intima. It's thinner, but it has this dramatically prominent, wavy internal elastic membrane.
But that waviness is an artifact. Right?
Yes, it's from the contraction of the thick muscle layer when the tissue is fixed for viewing. But it makes the IEM highly visible, separating the intima from the muscle of the media.
Now for the smallest, but arguably most important, small arteries and arterioles.
This is where control happens. A small artery has up to 8 layers of smooth muscle in its media. An arteriole has only 1 or 2 layers.
And the arteriole is the master regulator.
It's the primary site of resistance in the whole system. Because of physics, Puiseuille's law, even a tiny change in its radius causes a massive change in flow resistance.
So they control blood pressure and local flow.
Exactly. They control flow using a precapillary sphincter, a little cuff of smooth muscle where they feed into a capillary bed. And these sphincters undergo rhythmic contractions and relaxations, a process called vasomotion, to control blood flow based on local metabolic needs.
If arterioles are the regulators, capillaries are the destination, the true exchange zone.
And they're incredibly simple structurally, a single layer of endothelium on a basal lamina, but we classify them into 3 types based on their permeability. First, continuous capillaries.
The tightest ones, found in places like the brain and muscles.
Right. They have an uninterrupted endothelial lining with tight junctions, so most things have to pass directly through the cell via transcytosis, carried in little vesicles.
The second type has openings.
Fenestrated capillaries. Fenestrated just means windowed. You find them in places that need rapid exchange, like endocrine glands or the kidneys. The endothelial cells have these circular openings or fenestrations, but the basal lamina underneath is still continuous, acting as a second filter.
And the third type is the most open.
Discontinuous capillaries, or sinusoids. Found in the liver, spleen, bone marrow, they have large openings, wide intracellular gaps, and critically, a discontinuous basal lamina. This allows even plasma proteins and sometimes whole cells to pass through.
And wrapped around these capillaries are the pericytes.
Yes, these fascinating, multi-talented cells. They're mesenchymal stem cells that wrap around the vessels. They're contractile, they help stabilize the vessel wall, and they can differentiate into other cell types like fibroblasts or smooth muscle cells during vessel repair and angiogenesis.
So to circle back on capillary function, local regulation has big systemic effects.
Huge effects. For instance, when vasodilators cause arterioles to relax, capillary pressure surges, and fluid is pushed out into the tissue, causing edema. Conversely, widespread vasoconstriction lowers capillary pressure, which pulls fluid back into the blood away to rapidly increase blood volume to prevent hypovolemic shock.
But not all blood goes through the capillaries. The system has bypasses, arteriovenous shunts, or AVAs.
Right. AVAs are direct routes from an artery to a vein, completely bypassing the capillary bed. Their main job is thermoregulation.
So controlling body heat.
Exactly. To conserve heat, AVAs open up and shunt warm blood away from the skin's surface. To lose heat, they close, forcing blood into the superficial capillaries to radiate that heat away.
And we also have the medarteriole.
A medarteriole is basically the start of a thoroughfare channel, a direct path between an arteriole and a venule. And it's at the start of these that you find the precapillary sphincters, the final gatekeepers controlling blood entry into the capillaries.
All right, let's move to the return journey. The veins. They're generally lower pressure with thinner walls and larger lumens than arteries.
And we classify them into 4 categories. Starting small, we have venules and small veins. The smallest are the postcapillary venules, just endothelium and pericytes.
And this simple structure makes them leaky.
Highly permeable. They're the primary site where inflammatory agents like histamine work, causing fluid leakage, and they're the main exit ramp for white blood cells migrating into tissue.
But in lymphoid tissues, they're specialized.
They become high endothelial venules, or HEVs. The endothelium changes from flat to cuboidal. This special structure facilitates the massive migration of lymphocytes from the blood into lymph nodes and other lymphoid tissues.
As venules get bigger, they gain muscle.
Muscular venules get 1 or 2 layers of smooth muscle, which is their tunica media. Then you have small veins with 2 or 3 layers.
Next up are the medium veins.
This is most of the named veins. Their key feature is a relatively thin tunica media, but a very thick tunica adventitia, which provides most of their structural support. And of course, they have valves, especially in the limbs, to prevent backflow.
Which is where the clinical risk comes in.
Deep venous thrombosis, or DVT. Clots can form, often near those valve pockets. If a clot breaks off, it can travel to the lungs and cause a potentially fatal pulmonary embolism.
Finally, the large veins, like the vena cava.
They have a remarkably thin tunica media. Their thickness comes almost entirely from a very thick adventitia, which has these prominent longitudinal bundles of smooth muscle.
And they have another unique feature.
Myocardial sleeves. Extensions of atrial muscle from the heart that are embedded right in the adventitia of the venae cavae and pulmonary veins. And there's a clinical link here.
Atrial fibrillation.
Yes, AFib. These myocardial sleeves in the pulmonary veins can sometimes contain altered cardiac muscle cells that act as rogue electrical sources, triggering that irregular rhythm.
The chapter also points out some atypical blood vessels, starting with the coronary arteries.
They're muscular arteries, but they're atypical because they have an unusually thick tunica media. And with age, the subendothelial layer of the intima progressively thickens.
Which provide context for coronary heart disease.
CHD is an oxygen supply and demand imbalance, and atherosclerosis is the main cause. When a coronary artery gets 90% or more blocked, blood flow is critically compromised.
And an acute event, like a plaque rupture,
causes myocardial infarction. The muscle cells die. And because cardiac muscle can't regenerate, the dead tissue is replaced by a non-contractile, electrically inert scar, a permanent loss of function.
Another atypical vessel is the great saphenous vein.
Famous because it's often harvested for coronary artery bypass graft surgery. Histologically, it's atypical for a vein because it has extensive longitudinal smooth muscle bundles in both its intima and its adventitia, making it extra durable.
And finally, a very specialized vein in the adrenal gland.
The central adrenomedullary vein. Its wall has these big longitudinal smooth muscle bundles in the media called muscle cushions. Their contraction squeezes the adrenal medulla to enhance the rapid release of hormones like epinephrine into the blood.
And we return now to the lymphatic vessels, the auxiliary fluid managers.
Right. They return that final 10% of extravasated fluid, the lymph, back to the blood. When this system fails, you get lymphedema, that localized tissue swelling.
The lymphatic capillaries themselves have a very specialized structure.
They are completely unique. They're blind-ended tubes, they lack parasites, and they have a highly discontinuous basal lamina. Their endothelial cells are oak leaf-shaped, joined by these discontinuous button-like junctions.
Which makes them super permeable.
Extremely permeable, allows easy entry of fluid, large proteins, and immune cells.
How do they stay open when tissue pressure goes up?
It's a beautiful piece of engineering. The outside of the capillary is tethered to the surrounding matrix by anchoring filaments. When tissue pressure increases, these filaments pull on the vessel wall, pulling it open and preventing it from collapsing.
And as they get bigger, they become collecting vessels.
They get a continuous basal lamina and zipper-like tight junctions to prevent leaks. And like veins, they have bileaflet valves to ensure one-way flow. But since there's no central pump, lymph movement depends entirely on smooth muscle contraction in their walls and compression from surrounding skeletal muscles.
This deep dive really shows that the cardiovascular system is just a marvel of cellular specialization.
It truly is. From the heart, we saw the fibrous skeleton acting as both a mechanical anchor and a vital electrical insulator. In the vessels, the difference between an elastic artery, a pressure reservoir, and a muscular artery, a flow distributor, it all comes down to the ratio of elastic lamellae to smooth muscle.
And the endothelium as this active endocrine organ.
That's maybe the most critical takeaway. It's actively regulating flow through this powerful push and pull between endo and endophilin, a balance whose disruption kicks off major diseases like atherosclerosis.
It's just stunning. Right down to those oak leaf-shaped cells and the fibrillin anchoring filaments keeping the lymphatic capillaries open. We talked a lot about how losing elasticity in the large arteries is a hallmark of aging. Given that the smooth muscle cells in the tunica media are the ones making and maintaining that critical matrix, what future genetic or bioengineering solutions might we see that could target those smooth muscle cells? Maybe boosting their production of new functional elastin and collagen to restore arterial compliance well into a healthy old age.
A fascinating area of regenerative medicine indeed.
Thank you for joining us for this extensive deep dive into the histology of the cardiovascular system. We hope this comprehensive review serves you well in your studies and deepens your appreciation for the complex architecture sustaining life.
A warm thank you from the Last Minute Lecture team. Good luck.